The topic today is fluid resuscitation in critically ill patients. My name is Kate Brennan. Here's what I do. So I'm an assistant professor at Vanderbilt. I am ICU trained and I also do OB anesthesia. So that means that I kind of here at least do half the top thing and half the bottom thing. So the top is what our ECMO looks like. And then the bottom is what I mostly do in OB, epidurals, things like that. So some objectives for this lecture that I'd love for you guys to kind of get out of this is, number one, to be able to describe the reasons to administer IV fluids and then how to decide which type of fluid will be best for each patient. We'll go over some special situations that kind of go outside the normal rules of how much fluid and which one. And then we'll go over a little bit how to assess volume status. This is notoriously very difficult and sometimes impossible to do. And then we'll go over, I have 3 cases that it's actually great that you guys are all together because you can discuss kind of what your anesthetic plan would be for these patients and then what their ICU issues might be after they have anesthesia. So let's start with the goals of fluid therapy. So why do we give people fluids? Well, we want to maintain their intravascular volume, right? Especially if they're coming for a surgery, we know that they're going to have swings in what their intravascular volume is, and IV fluid is a way to help maintain that. We can use fluid to augment cardiac output. So this is specifically for people that are hypovolemic or people that maybe are bleeding. IV fluid can help to augment their cardiac output. We know that helping to maintain intravascular volume and augment cardiac output is a way to maintain tissue perfusion, right? So we don't want somebody to be going anaerobic respiration in their tissues and have things like lactate and things like that. It also can help to promote oxygen delivery, all of these things going back to maintaining tissue perfusion. And then we can use fluids to either correct an electrolyte imbalance or to maintain an appropriate balance. Sometimes we have to use fluids to correct an imbalance that we created with fluids beforehand. So some perioperative fluid management, because you all do anesthesia. So surgical conditions, right, cause us to need to give patients fluid. So blood loss, but also insensible losses. So the fluid that somebody needs from, say, a major laparotomy is probably close to 500 to 800 cc's of fluid per hour, just because there's so much insensible loss from a big incision and all of their bowel being exposed to the air and losing fluid that way. We also know that many times our patients are fasting preoperatively, sometimes a long time, and that sometimes they have pre-existing diseases that make it so that they need extra fluid administered. So most commonly, I think the most common thing that comes to the operating room is people that are vomiting or have fevers, but burn patients are another group of patients. I'm not sure if you guys see burn patients a lot, but they need an astronomical amount of fluid resuscitation just because the skin barrier is lost and they're losing hundreds and hundreds of cc's of fluid per hour just with losing that. We also know that our anesthetic drugs, right, cause peripheral vasodilation, meaning that we need more fluid to kind of fill up that tank so that people have appropriate intravascular volume. So let's talk about some signs of hypovolemia. So physical exam is usually enough to tell if a patient is hypovolemic. A walking, talking patient will a lot of times tell you that they feel very thirsty, but you might also see a narrow pulse pressure on their exam. You might see that if you induce anesthesia, they get very, very hypotensive, more than you would think for that type of patient and that amount of anesthesia that you use, or even when they stand up. So if you have the ability to do orthostatic blood pressure when they're standing, you may see an exaggerated response to them standing up. It's common to see cool skin and also delayed capillary refill. That's probably the most sensitive physical exam technique that you can use. If there's one thing you can do to say, is this patient hypovolemic, it would be to check their capillary refill. They may also be tachycardic. And if the patient has been dehydrated for some time, their urine output may be low. Lots of labs that are usually non-specific in all honesty, but can help you to kind of build this picture of, is this patient hypovolemic? So if you have the ability to measure a lactate, an increasing lactate or just a single high lactate can be a sign of hypovolemia. a creatinine that was normal and now is not normal is probably the most helpful, opposed to just one in isolation. If your patient's bleeding, you could see that their hemoglobin is low, and that might suggest that they're hypovolemic. They also might have hypernatremia. So this comes into play with our ICU patients a lot when we're diuresing. And we see that they get more and more hypernatremic. This may mean that they're not total body water down. So they may have lots of edema and have pulmonary edema, things like that, but they may be intravascularly depleted, which is kind of one of the more difficult things to manage in the ICU. So you can use ultrasound easily to assess for hypovolemia. It's difficult there's some studies that we'll talk about at the end of this, and I'll send you some of those studies. It's difficult to know kind of whether this is as helpful. Studies that are kind of mixed. However, I have found it, especially as a trend, very, very helpful in patients. And if you have ultrasound available, it's quick and easy to do. So looking at the IVC, so here's the probe position for that. I use the cardiac probe for this. You could also use, if you have the big curved probe, that will work fine too. Almost any probe, honestly, will work for this view. There's good data to show that a small IVC in a trauma patient means that that patient is bleeding. There's not as good data, but some to show that if your IVC is less than 1.5 centimeters, you're probably hypovolemic. And if it's greater than 2.5 centimeters, you're probably hypervolemic. We use respiratory variation a lot. The data on that is actually pretty poor. The original studies that looked at respiratory variation suggest that it has to be an intubated patient that's not initiating breaths on their own. A lot of times when I do this, my patients are not intubated. I still find that if the IVC completely collapses, right, so like looks basically like this, that patient probably could stand a little bit of fluid. And it's not that the patient needs fluid, it's that they will tolerate a little bit more fluid with this sort of exam. The other thing is just surface TTE, right? So this is a parasternal short axis view, and this is classically what you would see in a patient that was hypovolemic. So that's the left ventricle kind of right in the center of those two images. And you can see that it looks like it's very, very thick. And it's actually not, it's pseudo hypertrophied because the patient is just so volume down that there's nothing to fill up the left ventricle. So any view, again, a TTE view, either this parasternal short view or an apical 4 chamber view will show that if you have a left ventricle that's kind of just the sides of the walls are coming together every time the heart beats, that to me says that patient needs some fluid. So conversely, how do we know somebody's hypervolemic? And can they be both? And a lot of times people are both intravascularly depleted and total body hypervolemic. So physical exam again. So these patients usually have edema in their legs, their arms, anywhere that's dependent. A lot of times they'll have sacral edema. They could be hypertensive. So young, healthy people, a lot of times if they're very hypervolemic, will actually be hypertensive. If you have somebody with cardiac disease, however, they could be hypotensive, right? If we're giving them some component of cardiogenic shock in addition to just being hypervolemic. So not as reliable. What is more reliable is that they may be hypoxic. So if the patient has evidence of pulmonary edema, which a lot of our ICU patients do, that you could be fighting some hypoxia on the ventilator. And you may have increasing ventilator pressures. You may have to increase PEEP to keep their oxygen saturation up, or just increase their peak pressures to keep them saturating at an appropriate level. They may have other signs or symptoms of heart failure, especially if they have pre-existing heart failure. And then lab findings, not as helpful, I think, for hypervolemia. So sometimes these patients are hyponatremic. But again, hyponatremia can occur in all sorts of different volume statuses. That's more helpful as a trend. And if your patient does have heart failure or liver congestion, something like that, you may actually have an increase in creatinine with hypervolemia because you're not perfusing the kidneys enough, because you don't have enough forward flow from a heart that's very, very sluggish. So can we use ultrasound for this? Yes. And this is very, very easy. So this is some patients you can't get that IVC view because they've had surgery or they're obese or something like that. Or for me, they're pregnant patients. It's very hard to get that view in pregnant patients. But this you can get in all patients. So lung ultrasound takes less than a minute to do. The points that I use, there's a set of points that people use for lung ultrasound. They're the same on both sides. And they honestly they kind of start up here. And this is where I start. If I'm doing a quick lung ultrasound exam, I will usually just look at these 2 points and see if I see pulmonary edema in a patient that I suspect it in. It's very easy to do after you're doing your focused TTE. And what you'll see is these B lines. So you'll see these kind of radiolucent lines coming from the top of the screen to the bottom of the screen. If you see more than 3 in any one image, it's suggestive that the patient is hypervolemic. And sometimes they'll actually kind of all come together and be a big line. The whole thing will be kind of whited out. That is not your ultrasound technique. That is usually that the patient has lots and lots of water in their lungs. You also, for a patient that has existing heart failure, might see evidence of right-sided heart failure. So if you do this is again an apical 4-chamber view, those chambers are labeled, which is nice, but you can see that the right side is very, very big and the septum is bulging into the left side. So this is somebody that has chronic, likely chronic right-sided heart failure. And it's a pressure overload state, right? Because the septum is pushing into the left side. These people can be profoundly hypotensive, which can be a little bit difficult to figure out if you don't know that the patient has right-sided heart failure existing, or that you maybe are kind of pushing them into right-sided heart failure. So let's just go over some types of fluid that we can use. So I like to differentiate them into hypotonic, isotonic, and hypertonic. By far, the most common thing that everyone uses is isotonic fluid, like Ringer's lactate. There's lots of other types of fluid that's isotonic. So we have things like Plasma-Lyte and Normasol. All these are just different types of fluid that is supposed to be isotonic. Hypotonic fluid is more commonly used in people that have hypernatremia, things that electrolytes that need to be corrected. We have one ICU here, our surgical ICU, that runs D10 water as a sugar source for all patients that are NPO, and we'll talk about that a little bit later. That is reasonable in kind of small amounts. We do that at 30 cc's an hour for almost all adults, which is certainly not enough fluid to sustain them, but it's enough to give them kind of a sugar source when they're maybe NPO for days at a time. Hypertonic saline, hypertonic fluid. So I think 3% saline is the most common thing we use for that. And 3% saline, I don't know how much you guys use that, but it's really, really safe. We were taught, and kind of the traditional teaching for me, at least in medical school, was that hypertonic saline is unsafe and needs to be used with caution. And we give boluses of hypertonic saline of maybe 100 cc boluses without worrying about it. You can safely do that for a patient that you think has cerebral edema or is a little hyponatremic, things like that. I would say we most commonly use it in our neuro ICU for people that we're worried have cerebral edema. But you don't need to be as concerned about checking the labs and things when you're using small amounts like 100 cc's. So this is the makeup of our crystalloids, right? So we have our plasma on the far side of the screen, and then we have saline, Ringer's, and then Plasma-Lyte. The things I want to point out here are that, so normal saline, if you have anything else, use anything else. So we know that it's just sodium and chloride, right, in the normal saline. And here's the milli equivalence of that. They're both so high. This is a very, very acidic fluid. So the pH of normal saline is 5.4 to 5.6, and there's so much chloride in it. So what you do for people when you give them normal saline is you give them a metabolic acidosis. You can give anyone, and we give anyone, lactated Ringer's. So even people with DKA, we give them Ringer's instead, even though there's some potassium in there. It's so small, the amount of potassium, that you're not going to hurt somebody with DKA with that amount of potassium. Even people with renal failure, they get Ringer's. Almost everybody gets Ringer's. The only thing really saline is still appropriate for it is giving with blood, because we know that there's some calcium, right, in the ringers. So that will, it not always, but can cause the blood to precipitate, and you wouldn't want to lose some of the blood that you're trying to give somebody. So here's the things that people usually get nervous about in ringers is the potassium. There's almost no potassium in it. Anyone really, if they have hyperkalemia, it doesn't matter. They can still get ringers, and it will actually usually drive their potassium down. And then the calcium, people sometimes get worried about. I will say that sometimes I give blood with ringers and it's okay. If you have saline, it's better to do that with normal saline, but if you're giving it fast, you're usually fine. So let's talk about colloids. So the most common thing we use here for colloid is albumin, which comes in 5% albumin or 25% albumin. It's very expensive, and it's almost always the same as using crystalloid. So if you don't have it, or you're thinking, is this appropriate or not? It's almost never the right answer. And it usually is, the only thing is that it costs more. We know that there's one specific patient group that we should not use albumin in, and that's people with brain injuries. So anyone that has a traumatic brain injury, anyone that has cerebral edema, those patient populations, we know there's studies that show that albumin actually increases their mortality. Blood or blood products, also a colloid. And then there's a product, Hetastarch. I'm not sure if you guys have access to that. We don't anymore. And it's actually contraindicated in the ICU. There's this whole group of products that were made from synthetic compounds back in kind of the 90s, early 2000s, that we thought maybe would stay in people's blood vessels for longer, because that's the problem with normal crystalloid. But Hetastarch, it's such a big molecule that it actually causes lots of kidney failure and increases mortality in ICU patients. So let's talk about maintenance fluids. So in the ICU, we almost never use maintenance fluids, and that's probably one of the more common things we do is turn them off. So maintenance fluids really are for euvolemic patients that can't take PO. So someone that's had a GI surgery and needs to be NPO for 4 or 5 days or something for their anastomosis to heal, or something of that nature. These are great people that are otherwise young, healthy adults that are great for maintenance fluids. Ideally, you would provide an isotonic solution with glucose, but you can make this up from some Ringer's lactate plus some D5 or D10 to kind of combine those two to be an appropriate maintenance fluid. Again, we almost never use it in the ICU. The bottom, this traditional 4-2-1 rule that if you guys have done peds anesthesia, that's really where this comes into play. But you can see that, we usually, if someone's on maintenance fluids, it's maybe 80 to 100 cc's an hour. And again, it doesn't need to be one thing. So that might here be 30 cc's of D10 plus some Ringer's lactate to be about 80 to 100 cc's per hour. This really needs to kind of be reassessed continually though. So someone shouldn't be on maintenance fluids for a week or 10 days. It's really better to do this either in a 12-hour period or everyday period where you think, can this person eat or drink, or do I need to continue these fluids? It's very easy to get somebody very volume overloaded this way. And even young, healthy people, if they're sick in the ICU, you can make them very volume overloaded. And then you start to see electrolyte abnormalities that are pretty inconvenient to fix. The other patient group that I think is important to discuss is people with sepsis. So this, I'll send you all, if you don't have this article yet, I'll send it to you. This is the first article about goal-directed therapy, or kind of being cognizant of how much fluid you give septic patients. This is from 2001, and it's usually called the Rivers trial. So this is probably one of the most, or the most important articles in critical care in the past 20 or 30 years that showed that people with sepsis need IV fluids, and we were killing people because we weren't giving them any fluid. So this guy, Manny Rivers, he randomized a bunch of patients to get lots of fluid or basically no fluid. So his therapy, so he called this goal-directed therapy, and it was an initial fluid resuscitation of 30 cc's per kilogram. So that's a lot of fluid, right? So that's somewhere between 2 and 3 liters for most adults. And we really try to get that in the first hour to 2 hours that somebody presents. He showed that it really, really reduced mortality. And I think that was probably because the recognition of sepsis at the time was very, very delayed. And there's lots of other things that people weren't doing for people that were septic. They weren't giving them antibiotics in a quick manner. They weren't giving them vasopressors if they needed them in a quick manner. So there were lots of other things that went along with this trial that made it so people had a very, very much improved mortality rate. Now, though, we know that almost all septic shock has a cardiogenic shock component. So there's even this term, right? Sepsis associated cardiomyopathy. Almost all people with sepsis have some sort of heart failure associated with it. You can really hurt people with lots of fluid, even in sepsis. So for me, if I have a patient that comes in that is very, very septic, and doesn't have existing heart failure, I'll give them this initial fluid resuscitation. And most people usually get about 3 liters of fluid. Again, preferably not normal saline, because they probably also have tissue hypoperfusion, right? Thinking back to those initial slides. So you're only going to make their metabolic acidosis worse if you give them normal saline. Ringers, if you have it, is a much better choice. But then after that, if their blood pressure is still low, I'm going to just start something like norepinephrine. Peripherally, it doesn't matter, and go from there. So it doesn't matter so much what vasopressors you add after norepinephrine now. There's lots of new data that shows that just kind of anything is okay. It's reasonable, though, to consider in somebody with heart failure. A lot of times what we'll do is add something like dobutamine to the norepinephrine, or even epinephrine works great. And we just kind of see how people do with that. And the first thing that comes off is the thing that's not norepinephrine. So the norepinephrine stays on the longest because we know that helps them most. So again, fluid resuscitation after this initial fluid doesn't usually help and can actually hurt people. We know that after this initial inflammatory stage, people can get very, very edematous. They get lots of pulmonary edema, and then you're kind of in a worse place than you were in the beginning. So now what do? I told you not to give somebody fluid. What do you do when their blood pressure is low? It really depends. So we talked about sepsis as being a cause of hypotension that can be fluid responsive. Hemorrhage is, I think, a slam dunk. That one, if somebody is bleeding, you really should, number one, give them blood. So if you don't have blood, however, other things are appropriate. So crystalloid, anything that you can kind of get your hands on in a bleeding patient, if you're working on getting blood from someone, is a great kind of stopgap or temporary measure. In general, people that are hypovolemic, clearly on physical exam, someone that's been vomiting for a long time, you say, oh, this person is very tachycardic, their blood pressure is low, they will respond to fluid. So things like cardiogenic shock, neurogenic shock, they don't respond as well to fluid. And sometimes you just can't tell. So we use kind of some of the tools that I talked about earlier, but sometimes it's just not easy to tell if your patient will be fluid responsive. And the only way for you to tell is to try something. So either give them fluid or give them Lasix and see kind of what happens to either one. It's usually not that you've kind of bought one therapy, right? So if you give somebody fluid because you think, oh, I think this person is hypovolemic, or maybe they're septic or something like that, and they get a lot worse, and you say, ooh, actually their family came and they told me they have heart failure. It's not that you're tied to that, right? You can always diurese somebody. And the same thing if you give somebody a big dose of Lasix and you say, oh, actually, I think they were hypovolemic, or maybe they weren't ready for that diuresis, you can give them fluid back, right? So this is a dynamic process that changes sometimes even during your anesthetic, right? You think, oh, I thought maybe they had some pulmonary edema, but now their blood pressure is very low. And I think maybe I gave them too much Lasix. Give them a little fluid back and kind of test it and see if it works. So things that people have used and we sometimes use to help to figure out if someone's fluid responsive is CVP, so central venous pressure. This is terrible for telling if somebody is fluid responsive. And we, even though we still use it, everybody knows that it's not useful. So this is absolutely no reason to put in a central line in somebody. It's not going to help you as much as most people think it will. And it really only leads to kind of extra risk. So if you have a central line in place, sure, but I wouldn't recommend this for routine use. It's not something that's going to help you. IVC compressibility, I do use that. So if they have greater respiratory variation, they do tend to be more fluid responsive. So I use this as a trend. So maybe if you think someone is hypovolemic, give them 500 cc's of fluid and then look again, or give them a liter of fluid and then look again. The same thing with diuresis. If you think they're hypervolemic, diurese them and look at their IVC again. Especially if one person is doing it, you can kind of get a trend, and that can be a little bit more helpful. The one thing that is really great and is very easy to do is a passive leg raise. So this is probably the easiest way to tell if a patient is going to respond to fluids. Maybe not if they need fluids, but if it will make their hemodynamics better. So we do this a lot in the ICU. So we put people flat and then we raise both of their legs to 45 degrees. And I honestly do this just by standing kind of with my hands up and the patient's legs up in the air. You have to stay there for a little while. So you have to stay there for about a minute. But all the blood in their legs then returns back to their central vasculature pretty quickly. So between 30 and 90 seconds is about how long that takes. If the patient's hemodynamics improve, so if their heart rate goes down, if their blood pressure improves, things like that, you know that person is about 11 times more likely to respond to a fluid bolus. That passive leg raise is way better than CVP, IVC, all of those other kind of more advanced measurements. It's way better at determining that. You could even, if you were in the ICU with an echo, you could even have somebody looking at the heart while someone did this, and you would maybe see that the heart, the left ventricle got more filled with that fluid. And for that patient, I would say, absolutely, this person needs a little bit of fluid. So we talked about just giving fluid to see if it works. In the ICU, we do this honestly all the time. A lot of times it's, we'll give a little fluid, we'll see if it works. Maybe if it doesn't work, we'll give Lasix. But there are consequences, right, of giving fluid in critically ill people. So we know that it causes lung injury. So after the initial phase of critical illness, people that have hypervolemia will definitely get pulmonary edema. We know that things like pulmonary edema prolong time on the ventilator, and it also increases risks associated with the ventilator. So like we talked about before, you have to use higher pressures. So you have a risk of barotrauma or trauma from the ventilator by using very high pressures. You also have this kind of newly described risk that's called atelectotrauma. So you know that patients under anesthesia have atelectasis, right? So their alveoli get stuck together. So people on the ventilator in the ICU have the same thing, but we know that every time we provide them with a breath, we kind of pop that alveoli open. And then it closes again, and then pops up again, and then closes again. That in and of itself is traumatic to the individual portions of the lung. It can cause lots of inflammation and lung damage. We also know that giving people a lot of fluid increases their ICU length of stay and also increases mortality. So I'll send you guys this article too. It's pretty new, and it's a nice study that shows that people that got more fluid had an increased mortality over people that kind of had an assessment of their fluid status pretty frequently, and in general got less fluid. This on the side here is a meta-analysis if anyone hasn't seen this type of study before. So these are all the studies that they looked at, and then they kind of estimated the risk of death for people that had dynamic therapy, which was the frequent fluid assessments, and those patients got less fluid, over people that just got the standard of care. And you can see that this little caret here shows that it favors the frequent assessment. So those patients had a decreased risk of mortality. So let's move on to cases. So what I'd like to do is kind of, it's just great that you guys are mostly together and maybe someone else is with somebody on the other screen. So I'll give you guys a few minutes to read this over and then talk amongst yourselves, right? So for this first case, you have this young man who comes in with lots of nausea and vomiting. He has a perforated appendix and he needs to come to your operating room for surgery. He's a healthy guy. And I want you guys to talk about, for the next, say, take like 2 minutes, talk about your initial fluid management strategy, including what you're going to use, how much you're going to use, and then how will you know kind of when it's enough and when you'll slow down your fluid administration. I gave you some initial lab data and some vital signs data on this side of the screen, and we'll go from there.
This patient has been sick for the last 10 days, and he has nausea and vomiting, which is upper GI. So this will predispose the patient for upper GI loss, and our strategy is going to be liberal method, since we have to replace the deficit.
Mm-hmm.
And the type of fluid, nausea and vomiting, usually patients are predisposed for alkalosis. So it's better to use crystalloid, especially the normal saline, and fluid, 30 ml is appropriate. And we manage him accordingly if he's not responding for this volume resuscitation.
What do you think is going to happen when you induce anesthesia on this patient?
This patient is hemodynamically unstable. His blood pressure is low, tachycardic, and his febrile. Probably when we induce him, there will be post-induction hypotension.
Oh, for sure. And what kinds of things could you use to kind of mitigate that? He's a young guy, so no matter what you do, he'll probably be okay, in all honesty, but there are things we can do to kind of help smooth the course out.
We will select the induction drug like ketamine.
Yeah, sure. Something like using a different induction drug definitely would help. What about some fluids beforehand? Maybe give him a liter of fluid before he gets back to the operating room. That would probably really help too. I would say that even in this patient, I would give him ringers, just because you know that he's going to get a lot of fluid. And you're right, he could, nausea, vomiting usually does lead to kind of an alkalotic picture, but if he has tissue hypoperfusion, right? So he has a perforated appendix, he could have sepsis. He could have a metabolic acidosis, and probably does, right? Because his lactate is elevated. So probably has progressed for so long that he actually has a anion gap metabolic acidosis. But whatever, if all you have is saline, then use saline. But I would use a fair amount of fluid, right? So 3 liters, something like that would be kind of appropriate for this gentleman. And then he's going to have probably at least a little open procedure, maybe not a huge laparotomy, but at least an incision that's not tiny. Now that his appendix is perforated and there's probably a bunch of stuff in his belly that needs to get kind of washed out. So you know that you're going to have some insensible losses as well. So you need to kind of consider that as you're moving through this patient's case. So let's see what happened to him. So he got 5 liters of fluid during his appendectomy. Does that seem like a lot, a little, in the middle?
It depends our monitoring and our target.
Yeah, I think it depends on the patient, right? This might be really reasonable. If you're going on his urine output, right? And hemodynamics, he might have needed 5 liters of fluid, right? For this surgery. What do you think about extubation? Do you think you'll extubate this patient, and kind of what things are you thinking about before you decide that?
Extubated because the patient is hypotensive, and it's better to start even vasopressor.
Yeah, so anyone that's kind of hemodynamically unstable should at least warrant a conversation of, should this person be extubated? If someone has something like sepsis, like this man probably has, or something where you know why they're hypotensive or why they're a little bit unstable, and they're on a stable dose of vasopressor, I'll consider extubating them. But if that dose is changing a lot, or you're thinking, gee, I'm not sure why this person is hypotensive, Maybe they have cardiogenic shock. I'm not sure. You're right. That's a reason to keep them intubated. Any other reasons that anyone can think about? What about his oxygen saturation? For me, that would be kind of the number one thing. If he wasn't really saturating appropriately on a low-ish ventilator setting, that for me would say this person maybe has some pulmonary edema or some kind of lung injury from his sepsis that makes it so that he's not going to do well if I extubate him. So those are the kind of things that I'm usually thinking about in a sick person with bad sepsis that goes to the operating room. So this next one is more of an ICU case. So this is a 66-year-old woman that presents to the ICU with a 14-day history of cough and fever. You have her chest x-ray and some initial data. And then so same thing, kind of talk amongst yourselves. What do you think her diagnosis is? Would you give her fluid? And then any other things, initial tests or therapies that you would want to do for her?
From our discussion, the diagnosis is likely septic shock of chest focus, likely pneumonic effusion from the chest X-ray finding. And depending on after we scan whether the patient is fluid responsive or not, or depending on whether actually this patient is old and we can't rule out also cardiac problems. After we see the IVC, we can the patient with crystals, especially the balanced type, like active, regular active or plasma like. And how much? Just 30 minutes per day standard. And
this one's tough, right? There's this, I agree with you. You maybe should give some fluid to this person that maybe is septic from their, what looks like a pneumonia. And I think there is probably a little bit of an effusion there. Any things that you think might happen to this person if you give them fluids? And the thing that would make me at least take a second is that they're already hypoxic, right? So they're already saturating low on a lot of oxygen. What would you be worried about?
We are worried about pulmonary edema because the patient is on septic. So she may have developed pulmonary edema and saturation will be deteriorated. So we should be cautious on the fluid management.
For sure. She might get intubated, right? Like this might be, this is somebody that probably has a bad infection and needs a little bit of fluid, but their pulmonary status is so tenuous that even a little bit of fluid might make them get intubated. Do you guys have access to BiPAP or CPAP or something like that?
We have CPAP.
Yeah, sometimes that can really help in these situations. Just get you through that initial point where you need to give somebody kind of some antibiotics and things like that, just 48 hours for them to kind of get through. Because even a little pulmonary edema, you can fight that with a CPAP. And then for this woman, the other thing that she probably needs is early antibiotic administration, right? So we just give, it's great to get cultures from people, but in all honesty, half of sepsis doesn't ever grow anything. Just give them the antibiotics. Don't delay antibiotic therapy for any kind of labs or cultures or anything like that. It's more important to just get antibiotics into people. I would probably try a little fluid in her, maybe 500 cc's to 1 liter. I agree with you. I would use something balanced and see how she did. And I would just make sure to have the conversation that, hey, you might need to get intubated. So this is kind of a classic pneumonia patient that comes into the ICU. So 3 days later, this is that same person's chest x-ray. You can see that they're still a little hypotensive. Their heart rate's still up a little bit. They still have a fever. What do you think now?
This is third day, and blood pressure is going up, 90/64, and heart rate is 126. Still, she's febrile, and her saturation is 85, despite she is on 10 liter, and WBC is regressing from 20 to 17.8, and her lactate 0.1 from 7. So this shows there is somewhat perfusion. So there is tissue perfusion. She's getting out of his septic shock.
I agree. And now has bad pulmonary edema, right? So even though her blood pressure is maybe marginal and she's a little tachycardic, this type of person is almost ready for diuresis. So the heart rate may be up because the temperature is still up, which is normal, right? For days after we have antibiotics on people, for their temperature to kind of stay up as we get control of an infection. This might be somebody to try a small dose of Lasix in, even again, though the blood pressure is a little bit low. And you're exactly right. Things like lactate decreasing make me much more reassured that the person will tolerate a little bit of diuresis. Okay, last case. This one I think is also, it's more anesthesia based, but kind of a little tougher. So you have a 55-year-old male who has a history of a heart attack and he has resulting heart failure. So heart failure with reduced ejection fraction, who comes for a colectomy for colon cancer. He takes enalapril and metoprolol at home, and he has an echo that shows that he has a left ventricular ejection fraction of 30%. He has some moderate mitral regurgitation, probably from his MI, and he has a right ventricular systolic pressure of 50 millimeters of mercury. So to kind of talk amongst yourselves about what your anesthetic goals for the case are, and then how you're going to manage this person's fluid status.
The patient has heart failure, systolic heart failure. The ejection fraction is 30, it's less than normal. And I have to be careful. The drug is causing myocardial depression because I have already said the patient has systolic dysfunction, and we have to be even cautious over fluid management because the patient had look like pulmonary edema because the systolic right ventricular pressure is elevated somewhat. Pulmonary hypertension, and even we have to be cautious on fluid management.
Yeah, you know this guy has some right-sided heart failure, right? It's probably chronic. But this is somebody that could easily, be pushed into pulmonary edema from his right-sided heart failure. And you're right. In addition, he has left-sided heart failure. So for him, I would try to keep him as close to his baseline as possible. And I would rely much more on vasopressors. So any vasopressor, phenylephrine, norepinephrine, ephedrine, anything you have to keep his blood pressure up while giving him kind of on the lower end of what is appropriate for fluid. You know, he's having a colectomy though, right? So a big open incision, he's going to have lots of insensible losses. You'll need to use things like urine output, other measures of appropriate kind of perfusion to figure out if he is getting enough fluid, because I would hedge on giving him less for all of the things that you mentioned. So you induce the patient, and the induction is perfect, but right kind of 10 minutes afterwards, he becomes hypotensive. His MAP is 45 to 55, and you kind of try a couple things, but you can't get it to increase. What are your kind of initial management strategies for this type of patient?
This patient may need fluid like low dose, like 500 or 250 ml. Then if it's not responsive, we'll give pressors like norepinephrine.
Yeah, I would hedge on using something like norepinephrine. You could give him a little fluid. I think that would be reasonable. Is there anything about this patient's history that might make him more likely to be hypotensive or more likely to have refractory hypotension?
Yes.
The patient has a MI and she's
so he has heart failure. Is there anything that he's on medication for, maybe for his hypertension or his heart failure, that might make you think, oof, he might be pretty hypotensive throughout this whole case?
She is taking metoprolol.
And she was on enalapril.
The enalapril will really get you. If somebody's on a beta blocker, they should stay on it for their surgery. If they're not, you shouldn't start one kind of right before surgery. Even if they need it, it should be after surgery, but that enalapril will get you. And these patients sometimes have resistant hypotension, and you really need to just give them a bunch of vasopressors. So norepinephrine, if you have vasopressin, great. That sometimes works better, but in all honesty, norepinephrine works fine. And they can kind of trick you into thinking they need more fluid when really it's a medication, especially if someone takes it at night and took it the night before, that can make somebody hypotensive. Any kind of tools or other things you can think of that would help you decide what to do for this patient throughout the case?
So for this patient, if there's available, we can thoracic or transcardiac cardiography, so we can measure the cardiac output and accordingly.
Yeah, if you can, this even kind of a before and after, or if the patient's in recovery and has some hypotension, sometimes that's easier than when they're actually having a surgery. Although you might have some room kind of on the chest when someone's doing a laparotomy, but this is the type of patient that is great for some sort of echocardiography, even as just a trend to help you decide, do they need fluid? Do they need vasopressor? Do I need to give them a little diuresis to help their hemodynamics? You can always email me, or WhatsApp is totally fine too. Sometimes I don't see the WhatsApp for like 12 hours or something like that. So as long as that's okay, but happy to answer any questions about fluids, ICU, anything.